Thanks a lot, Dr. Magdi. Dear Chairmen and colleagues, it's my pleasure to present my talk today in this distinguished and esteemed Cardio Egypt conference. And I'm welcoming all of you in this Cardio Oncology session. And I'm going to talk about the key insights and emerging researches which will shape the future of Cardio Oncology. Actually, the treatment of cancer at first glance seems like an integral success. And since the late 1990s, there has been a steady decline in cancer-related mortality, mirrored by a steady increase in cancer survival. However, this progress is overshadowed by the risk of chemotherapy-induced cardiac toxicity, which accounts for a mortality rate as high as 60% by 2 years in patients who develop heart failure from cancer therapy. What are the future perspectives in cardio oncology for 2025? Actually, prior to 2022, we were in a dilemma. Each site has its own consensus, and clinicians were in dilemma because there is no protocols. By 2022, we have the guidelines of the European Society of Cardiology. We are now talking a common language, and we have evidence-based protocols. So what's next in 2025? Actually, we have a lot of publications throughout 2024 and 2025 early in these 2 months with new concepts in cardio oncology. And we are going to discuss the trendy publication throughout this period. The first of all, there was an urge actually to validate the European Society guidelines in clinical practice. One of these guidelines was the risk stratification. We know that risk stratification is very important, as those with high risk, they will need primary prevention. And we have a lot of scoring systems like the STREAM and the SCORE2 system. However, the one which was proposed by the European Society of Cardiology was the Heart Failure Association ICOS risk score. And according to various cardiovascular parameters, the patients are categorized into low, medium, high, and very high risk groups. This is a study in which 1,066 cancer patients receiving anthracycline were subjected to this heart failure ICOS score, and they were stratified into low, medium, high, and very high risk. And it showed a very clear correlation with symptomatic or moderate to severe asymptomatic cardiac toxicity with all-cause mortality rate. So it was validated, and it was very effective, this scoring system. The second one was to validate the biomarker criteria on the incidence of cardiac dysfunction. What did they find? They found that the incidence of mild asymptomatic cardiac toxicity was the most frequent if it is assessed by just biomarker activity. But what's interesting, they found that the incidence differ markedly depending whether cardiac troponin assay T or I was used, and whether it is sex-specific or neutral. And the second point is that it was of no prognostic value, this biomarker assessment. Hence, they concluded that revised version of ICOS definition for biomarker assay is to be clarified. After validation of the ESC guidelines, there was an urge for novel biomarker for early detection of cardiac toxicity and starting primary prevention for these patients to prevent the irreversible cardiac damage. What's written in the publications is the microRNA. What's microRNA? It's a circulating epigenetic regulator, and it is involved in the pathogenesis of the cardiac toxicity. It was found that it's superior to troponin T and brain natriuretic peptide, and it rises earlier than these biomarkers. The most important is the 34A microRNA, especially that it is involved in the pathogenesis of cardiac toxicity. However, in clinical practice, we need just validation and more clinical research to be used as a guideline. What's interesting also is the gross differentiating factor 15. It's a promising potential biomarker in cancer diagnosis, and it correlated well with the brain natriuretic peptide and troponin T in cancer patients, so it is very promising. Another interesting point, which was released by 2025, that the gross differentiating factor is a marker for further bleeding, okay? And they say that if it is added to the bleeding biomarker profile, it will increase its sensitivity from moderate to high value, okay? So we are looking for these biomarkers. Of course, we have a lot of other biomarkers, but they are not like galactin, high sensitive C-reactive protein, but all they are on experimental still use. These are which are published on 2024 and 2025. The last point which I will talk about is the novel therapeutics for cardiac protections. We all know that we have severe cardiac toxicity, and our main goal is early detection and prevention through cardiac protection. We all know that neurohormonal drugs like AC inhibitors, okay, they are used a lot for cardiac protection. However, many clinical trials fail to find a cardioprotective effect for them, in spite they improve the ejection fraction. So there was a need for novel cardiac protective drugs. In the PROACT trial, what did they assume? Do AC inhibitors help prevent cardiac toxicity in patients treated for breast cancer or lymphoma? It was a multicenter study done on breast cancer and non-Hodgkin lymphoma for those who receive anthracycline high dose, and they were subjected to enalapril and placebo. All of them had negative cardiac troponin. What did they found? That there was no statistical difference between the two groups, provided that the primary endpoint was the reduction in GLS or ejection fraction, or use of biomarker to detect cardiac toxicity. And what did they concluded? AC inhibitors are not likely to play a role in the future efforts to prevent cardiac toxicity associated with anthracycline, and a goal for the future should be targeted to a new drug candidate before starting again on any other preventive study. So, what are the novel cardioprotective drugs? We all know that in heart failure, we have a lot of drugs which prove to be very effective, and they are used as one of the four pillars of the heart failure therapy: sacubitril, neprilysin, mineralocorticoid antagonists, and sodium glucose L transporter inhibitors. All of these raised the hypothesis: as long as they prevent the heart failure, why not to use them as cardioprotective? And what's new is the dantrolene, which is outside the box. It's a drug outside the box, and they started to use it. In the SARA trial, okay, it was a randomized trial, and they tried Entresto versus placebo. The primary endpoint can reduction in GLS 15% at 6 months, and it was effective with a statistical significant difference between the two groups. And the current data suggests that sacubitril valsartan may prevent subclinical left ventricular dysfunction, and the adverse cardiovascular events were rare over this relatively short period of 6 months in this small cohort from single center. The European Society of Cardiology is running another study on the Entresto, but will be released the results by 2027. Another interesting paper was, sorry, just 2 minutes. If you please, can we add 2 minutes? In this study, they tried a lot of cardioprotective drugs and versus placebo. And what did they found? It was a multi-center, it was a meta-analysis, okay, involving 33 randomized clinical trial on 3,000 patients, okay? And what did they found? That the mineralocorticoid antagonist was the best as cardioprotective, okay, and in prevention of ejection fraction reduction and elevation of cardiac troponin. IMPA trial, IMPA pilot trial, it was found also to be effective in cardiac protection. What's dantrolene, which is the new drug? Dantrolene is a muscle relaxant used for treatment of malignant hyperthermia. The advantage of studying the genetics and the pathogenesis of cardiac toxicity had found that what does doxorubicin induce? Induce in the cytoplasm, cardiac myocyte cytoplasm, in the receptor, okay, change in this receptor with leakage of calcium, and this calcium influx is the cause for cardiac toxicity. So they stabilize this receptor either pharmacologically with this dantrolene, okay, this drug, or genetically by amino acid gene mutation. And why they found that it reduced in mice models the cardiac toxicity a lot. Even if it is given just for 7 days post anthracycline, okay? So they concluded that it's a promising drug, okay? And the findings suggest it's a potential for repositioning dantrolene in cardiac, in doxorubicin cardiac toxicity. That was 2025. Okay, my take-home message is that focused initiative is crucial to augment awareness of novel therapies in mitigating anthracycline-induced cardiac toxicity. We have to translate our clinical trial findings into tangible clinical benefits. This will hold a promise for making anthracycline-induced heart failure a rarity in clinical practice. And thank you.